Dr. Philippa Whitford.
Thank you very much, Mr. Speaker. I certainly welcome that in recent months, since a hearing of the Health Select Committee, that the Secretary of State for Health has stopped using the 10 billion figure and recognises the £4.5 billion figure that is much closer to reality. Because spending is normally allocated on the basis of health spending, not just NHS England. And the increase in NHS England was at the cost of significant cuts to public health, even though we all recognise the need for prevention, and cuts to Health Education England, despite the attempt to have 1,500 extra doctors every year and extra nurses and 5,000 extra GPs. So this is kind of rather a challenge. Now, last year, as has been said, was the good year before we come to the lean years. I'm not going to go into the details of the pockling that was required to get anywhere close to the required outturn, which was missed by £207 million, as that has been so clearly extolled by those of the Public Accounts Committee. But what it does result in is what the Auditor General described as short-termism. People simply working to meet the bottom line instead of lifting their chins up and looking at what the real challenges are. And there are three big challenges. We have talked about the ageing population. We recognise that we have significant workforce challenges, and we all know that money is tight and doesn't grow on trees. But these three things create a conflict, and what we are sometimes seeing is that people are doing a short-term patch that is actually going to cost more money in the end. I think that the providers across England can be recognised for getting their agency costs down, although they are still more than twice what they are in Scotland. But what's lying ahead? How are we going to avoid the challenge of providing workforce after Brexit? How will we avoid the challenge of not just people leaving, but how will we recruit in the future? The turnover at the level of nurse and social care worker is about 25%. And therefore you actually need a constant stream. And as one of the members on the government benches mentioned, the tiny proportion of population we have below 65 of working age is exactly why we needed immigration in the first place. So, are we going to end up with more agency workers, or will the government actually take action to make sure we can attract nurses, doctors and social care workers from Europe? Now, a lot of these problems are blamed on an ageing population, and in actual fact, in Scotland, our demographics are worse than yours. Going through a hard winter, as we've all faced, we didn't meet our A&E target either. But in Scotland, the emergency department 4-hour achievement was 92.6. In England, it was 79.3, the worst level since records began. This shows that there's a real crisis. Now, this is not meant to be a measure for us to attack each other with. And I have to say that in general, I think this has been a great debate tonight, rather than what some of our debates are like. It is meant to be a thermometer to take the temperature of the whole system, not just the whole hospital system from A&E to discharge, but actually from home to GP to A&E to hospital and getting back home again. And that's where the problem lies, is the cuts that are outside Department of Health, but yet are in social care. And they have been significant. And obviously, patients require that support to be able to get back into the community and preferably even to get back to their own homes. So despite our demographics, why is it that we are managing to keep our nostrils above water and in NHS England we're not? Well, part of that is because in Scotland we have focused absolutely on integration rather than financial competition. Now, the convoluted system that now exists between CCGs and outsourcing contracts and bidding and tendering is estimated to take £5 to £10 billion out of NHS England's budget. That would be enough to cover the deficits. That would be enough to plug the social care hole. But yet the Department of Health doesn't even keep data on it. So they are not keeping track of how these administration costs are growing. So there's no possibility of a cost-benefit analysis of bringing in outside providers and causing what we've got, which is this fragmentation, instead of people being able to work together. In Scotland, we've gone down the road, as I've said before, of integrated joint boards between health and social care, taking money from both sides so that you don't have the argument over whose purse is funding a patient. We've used other innovative approaches, such as community pharmacies, which we have debated here, minor ailments units within community pharmacies, and using those services. And because of that, the increase in attendances at A&E in Scotland has increased in the last 5 years by 3.4%. In England, it's 11.8%. That's 3 times the rate of attendances. And with admissions, it's similar. Our admissions, our emergency admissions, have increased by 4.6%, while in England they've increased by 14%. And all of that is because the effort is not being made in the community. There's a lot of talk all the time about the 5-year forward view. Frankly, we're halfway through the 5 years. There's only the 2.5-year view left. That isn't far enough ahead. In Scotland, we did Vision 2020 as well. We did it back in 2011. We are working on 2030, by which time the number of people 85 and above will have doubled. And that's what we need to be thinking about. How do we design our social care services, but also our health services around the ageing population? Now, our Cabinet Secretary is focused on what keeps people independent. Now, you might think that's because I'm SNP, but I mean people being independent and living high-quality lives. So what is it? Well, it's hip replacements, it's knee replacements, it's eye surgery. If you can't see and you can't walk, you're stuck in your house, you're lonely, and we are going to have to look after you. So what we've invested in, and it's often laughed at here, is free prescriptions, so people take their medication to control their chronic illnesses. We have invested in having people having free personal care in their own homes so that they're not landing in hospital and they're not getting stuck there. That's why delayed discharges for us last year went down 9%, while it went up between 25% and 30% here. And the other one, the free bus passes that people laugh at. The member opposite who mentioned loneliness, obviously as was championed by Joe Cox, as big a killer as diabetes. Older people in our community are out and about. Yes, they're taking day trips. Yes, they're going shopping, and they're loving it. They're not stuck in their houses. So it's actually starting with looking at that population. STPs are the best chance going forward. But at the moment, they're being handed a bottom line and being told to work back from it. It can't be budget-centred care. It must be patient-centred care. And all of us across the House can recognise place-based planning for a community is going to provide the best service to those patients, to your constituents. And that's what we should be doing. So getting real about public health and preventing that chronic ill health in later life. And that means health in all policies. A thing that is really bad in this House is we look at individual decisions day by day that completely contradict each other. And yet, if we were always thinking in every decision, will this make our citizens' health and well-being better or worse? And if it's making it better, in the end, it will save money. And that includes poverty, the biggest cause of ill health that exists. So I call on us to look at the systems, to look at how we do things, but we need to provide the care in the community before we take it from the hospital. But let's also think a little bit broader in some of the other decisions that we make. Yeah.